a homework review. We gave you all homework last week, and we're going to kind of leave that towards later in the presentation because we've got a guest speaker, Leah Miller, who needs to get to the airport. So I just want to ground you a little bit in what it was we talked about last time we met and what this series of the Learning Collaborative is all about. And then I'm going to make a few remarks about integration, and I'm going to turn it over to Leah. Leah, are you okay with that?
Leah, you might have to unmute.
Oh, Leah, do we have you on voice?
Maybe she needs to know that there's another dial-in, just to dial the phone number at the top under presenter notes.
Okay. Leah. Could I ask you, Leah? Okay, let me see if I can, are you able to dial in? Let me see if I can get this for her. Paste. All right, so we'll just wait a second for her. In the meantime, I will start, we'll skip past our homework review. So those of you who didn't quite complete the whole thing, you got an extra few minutes to get it together in case we pick on you and call you. So we're talking about integration. The whole purpose of this learning series is to understand what we mean by integration and where it needs to occur in value-based contracts and what it means in the particular context in which we're applying it. We tend to throw integration around like, you know, it's patently obvious what it is, and it's really not obvious, and there are lots of different types of integration and lots of degrees of integration, and the extent to which they matter in your value-based contract depends on the actual structure of your value-based contract, and we'll talk about what that means this whole series. So, you know, backdrop is when we're dealing with Medicaid, we're dealing with a more fragmented system of care. People go wherever providers will accept Medicaid reimbursement rates, which, you know, as value-based contract holders, it makes it more difficult for your organizations. What you see is what happens within your four walls. What you don't see is everything else. And if we're really serious about whole person care, then we have to think about integrating all kinds of things, not only different types of services, different types of information, and we've got to define what the integration means. So that's the point of the whole series here. So also remember, we'll talk a lot about integrations, but they're a means to an end. And I think we get off automatically on the wrong foot when we start talking about integration as an end point. It's not an end point. It's a means. It's one strategy of many to get to whole person care. And so one of the things we wanted to talk about today was, in the process of beginning to identify what sorts of integrations you would need and with what sorts of entities for what sorts of services and information. It all starts by, reading your contract, and we had an exercise in sort of reading the contract and understanding how value-based contracts are structured and beginning to talk through some of the implications last time. And this time we're going to focus on, okay, so we know we need integration, but we don't know how much and what kind. Let's talk about the cohort, who the cohort is that we're going to serve. And if we understand that cohort and what it is that makes them a cohort, the characteristics of being a group of people, and what it is that drives their utilization of services today, and generally what their health status is and their demographics, we can begin to understand what it is they might need. And then we can make the decisions about, oh, okay, depending on what they need to achieve better health outcomes and lower total cost of care and all those other good AAA wonderful things. We understand who they are as a cohort. We understand what they need. We can understand then and have a sensible conversation about what integrations might be needed and what those look like. So one way of thinking about this is to do some population segmentation. And so from a clinical standpoint, this is a very quick and dirty way of doing it. As risk increases and as per member per year costs increase, you could take your population and bucket it just on sheer costs, for example, and say, okay, if I've got information about what a patient or a cohort of what a patient has spent, I could just make arbitrary buckets, $0 to $1,000, $1,001 to $5,000, $5,000 to $15,000, $15,000 to $30,000, and everyone above $30,000 is just expensive. You could do it as simply as that. You could also do it on age. We've learned from a lot of risk modeling and a long history of risk modeling in this company that demographics are roughly 30 to 40% of projecting risk. So just with age and gender, you can use that as a way of bucketing cohorts. So even if you don't have any cost information, any total cost of care information, or any other cost information, simple demographics would be a start. Alternatively, depending on what information you have, you can start to bucket into clinical groupings, and this is a quick and dirty way of doing it. Who are your patients that are generally healthy? For those patients, what you might be then trying to do is say, well, they need sort of good preventive care depending on age and gender. There are certain screenings that apply. They're generally healthy. We're going to focus on getting the kind of the well person and screening information and maybe vaccinations, things like that they need. Those people are different from a cohort that's diagnosed with an acute illness. So depending on what the acute illness is, you may or may need different types of integration. Oops, sorry, I'm getting a message up here and I'm not sure what it is. Says, Carol, please use the presenter chat. I'm not sure what that means, but okay.
Natalie, let me interrupt you. AJ, Leah can see the screen, but we can't hear her. So any tips?
Right. I would. Can you look at the presenter chat? I gave a number for her to call me.
Oh, sorry. Got it. I'll get it to her. Sorry, Natalie. Go ahead.
Okay. So you've got people who are diagnosed with an acute illness. You depending on what type of a facility you have, you may or may not know about that acute illness. The patient may tell you that that something occurred afterwards, or you may have a relationship with your local hospital where they let you know that somebody has been admitted for, say, a car accident or another acute illness. One of the things you're more likely to get from your EMR is whether or not somebody's living with one or more chronic conditions. And we can talk about how to bucket chronic conditions later. That's a cohort that probably needs something different from a cohort experiencing catastrophic illness, for example, multiple sclerosis or a cancer, for example, and that all is quite different from approaching end of life. So each of these cohorts or segments is going to need to be thought of slightly differently with regard to the kinds of specialists you might be working with, the kinds of facilities you might steer them towards, the kinds of diagnostics you're going to need to understand for them, the kinds of medications they need to take, and then other home or community-based support. So this
Natalie?
is one. Yep.
This is Sherry. Sorry, there was a question. They wanted to know what PMPY stands for.
Oh, sorry. Okay. A PMPY is a per member per year. So in the insurance world, and as you become more more kind of attuned to the risk-taking lingo in your value-based contracts, you'll hear things like total cost of care or per member per month. That is the capitated amount, the per member per month, or you can convert it by multiplying it by 12 to a year, that a payer gives to an entity taking financial risk for total cost of care for a patient. So each patient gets, depending on, it's usually adjusted depending on demographic factors and then burden of illness and utilization. But a per member per year cost, how much money do we think this individual is going to spend in medical expenses and costs per year? And that's the premium rate, essentially. Does that make sense? Okay, so there are more sophisticated, so these kinds of buckets are buckets that you might be able to create from an EMR. If you get EMR and clinical and or claims information, many of the analytics engines on the market today have had their roots in claims analysis, and the more sophisticated ones have grown into using clinical and integrating clinical and claims, because you need both to understand a population and where they've been and where they might be heading. Not all of the ones on the market today are really good about taking as much clinical information as needed and really integrating it successfully with the claims data. Usually they're taking little snippets of some clinical information and some claims. So look for the ones that do a better job of truly harmonizing across multiple sources. So the way these engines usually work, though, are you feed data into them, in this case medications, lab, claims. You can also, the better ones have the ability to take in self-entered information or patient information. It could be an assessment that was done on a patient, a determination of needs, for example, or a PHQ-9. And they, in essence, mash it all together to create patient-centered profiles. And those patient-centered profiles then can be used for lots of different things. They can give you kind of a care history of a patient, where they've been, what kind of utilization have they had, how many visits to the ED, who are the providers that are treating them today, and sort of think about it as a kind of a little mini longitudinal personal record. The good ones also do additional analytics to give you prospective risk scores. So if this person costs, this much today or in the last year, what are they likely to cost in the next, say, 12 months or 6 months? Or what is their risk of incurring behavioral health-related expenses given their historical utilization and unique risk factors? So good analytics engines also tell you something about care opportunity, meaning, all right, given the age, gender, diagnoses, and historical utilization, what gaps in care would this person have? And they can also enable you to set case definitions. And it's that setting of case definitions that's in essence creating cohorts of patients that are useful to think about in terms of interventions, including the types of integrations you need with other providers or community-based resources. So this is an example of an actual structure of segments that we did for a client. I can't tell you the client. It was a Medicaid health plan, a big one, multi-state. It was not United Healthcare.
Yeah. No, I haven't had any since our last conversation, but we are planning an advisory board meeting around those, with one of that being the topic.
So this is Carol, sorry to interrupt, Natalie. Could participants put their phone on mute, hit the mute, the icon at the top of the screen? We're hearing somebody talk about planning an advisory committee, and I think you'd want to keep that confidential. Thanks. Leah, are you on yet?
I am. Can you hear me now?
Oh, yay!
Natalie,
hi.
I'm up. Glad you're on.
Good.
Hey, Leah, I'm just going to motor through this. It'll take me a couple of minutes. We can come back to it if the group would like.
No, it's fine. Go ahead.
About 8 or so.
Sorry about that. So this was just, this is just one way of taking information that we had. In this case, it was predominantly claims information, and using an engine kind of like I described here to come up with different cohorts and to think about in these cohorts. For example, if you have one of the chronic big five, congestive heart failure, coronary artery, COPD, asthma, and care gaps, and you're using a lot of inpatient or ED use services, what you want to think about with regard to integration is probably different than if you have some of those chronic conditions and a behavioral health diagnosis. The service set that a person with this constellation of illnesses needs is different from this one is different from this one. Am I stable, meaning, okay, do I have a diagnosis of a common chronic condition? Does historical evidence show that I'm taking my medications consistently? For a cohort that's chronic and stable, your integration needs are probably quite different than if they're unstable, meaning they're, seeing a lot of services at a lot of different places. So we'll give you this deck. This is just, again, it's just a way of looking at sections of the population to be able to start to tease out the types of integrations you need. For example, if you have total cost of care for a group of patients who have dementia and are in memory-assisted living or are still in the community, what you will need to do to keep them safely and happily in the community is quite different than, for example, somebody living with sickle cell. So we typically use claims to create these types of cohort, and then from there figure out what our networks need to look like, which is another way of saying integration. So there are lots of, as I said before, we tend to throw integration around, and we're not always clear about what it really means. And we're not always really clear about how it's different from coordination or co-location. Those are types of integrations, maybe. It's a big semantic discussion, and it deserves some unpacking as you think about who it is you're trying to serve and what it is they need and how you're going to have to figure that out and collaborate with those other entities and what degree of integration you really need. So at this point, I'm going to turn it over to Leah Miller. And Leah has a long history of working to support people who live with serious and persistent mental illnesses and kids with serious emotional disturbances in Tennessee. And she has some great stories and lessons learned about integration versus co-location or other types of what we commonly call integration. She's going to take it away and talk about her experience and lessons learned.
Thank you, Natalie, and thanks everyone for having me today. As Natalie mentioned, I am a behavioral health clinician. I'm based in Tennessee. I have been in Tennessee now for 20 years, actually this year. And when I first came to Tennessee, they were right in the process of basically trying to integrate managed care, medical and behavioral, all within managed care organizations. And this was at a time when Clinton and Gore were in the White House. Gore is from Tennessee, and there was additional federal funding to really help try and move towards that universal health care coverage. So there was a lot of additional funding infused within Tennessee, and the state at that time tried to move behavioral health into managed care. I came on into Tennessee when they were actually starting to pull it apart because they had launched it in 1994, and when I came in, they were basically going back to having behavioral health organizations separate from managed care organizations, basically viewing the integration of medical and behavioral under managed care as not working for a variety of reasons. So I worked with one of the behavioral health organizations at the time, and did that for a number of years.
Johnson.
And saw the benefits of definitely having a carve out around behavioral, but also saw a lot of the weaknesses in the model. One of the primary ones being is that nobody had a holistic view of the member. And then kind of flashing forward, in 2001, I started working for the State Department of Mental Health and Developmental Disabilities that was responsible for the behavioral health benefits being administered under managed care, under Medicaid. So for a number of years, I worked within the state basically to oversee how the behavioral health benefits were administered, and we then got a new governor who decided that one of his key platform strategies was to fix TennCare. And his way of fixing TennCare was to move it back into integration with a lot of lessons learned. I'll say my view on it in retrospect. What didn't work in the 90s was the idea of putting behavioral health under the MCOs without proper safeguards, without requiring unique reporting, without oversight and expertise being required of the MCOs in order to ensure that they really were positioned to understand behavioral health and to be able to deliver around an integrated model. So in 2007, behavioral health came back into the MCOs, and I was on the readiness review after working on the RFP stateside, and was asked to come over to United Optum, basically to help implement it. And so that's how I ended up for the last 10 years being within the United Optum family. The TennCare contracts have been extremely successful this second round of integration. And it's been rolled out in all of the different regions of the state in 2007 and 2009. And when we started that work, we made sure that we really looked at all of the stakeholders that were key players in the success of integration this time around. With regard to the needs analysis that we did, we made sure that we were able to really work with state, work internally in the health plan around integration, engaging the providers in integration, and then ensuring that the members and advocacy groups, family members, that they were all at the table as well. Because we regarded it as basically like a chair that has four legs, and if we weren't supporting all four of those legs, then the chair wasn't going to be able to support anybody. And so the bullets are there as far as some of the things that we really focused on. With regard to the state, we looked at licensure. Does licensure promote integration? What are the barriers to it? Are there funding streams or silos within the government that make integration difficult? What are the political commitments? Like our governor was very focused on integrating medical and behavioral across the state. So stateside, within the health plan, and we'll go into all of these bullets in the next slide in more depth, but really made sure at the outset that we had a very good idea of what the market was saying, what was needed, and what it was that they would support. So in essence, if you're looking at integration around a continuum, you need to know where on the continuum they are for stage of change. Because if you go straight to, and Natalie had a slide up that showed a continuum of 6 different boxes, if you go straight to the far right and who you're working with within the state or within your area is sitting way back on the left, you're going to have all kinds of issues with buy-in and success in getting to integration. Okay. So the key goals that we set out with at the time were to improve member outcomes and closing gaps in holistic care. So we wanted to make sure that we looked at individuals from a biopsychosocial approach. You know, medically, behaviorally, socially, what was it that they needed and what was missing in their communities with providers and so forth, so that we could help fill those gaps, as well as increasing access to care in least restrictive, most clinically appropriate settings. We wanted to overall reduce cost of care and increase provider accountability for outcomes, which included partnering with them, incentivizing them for positive results. So a number of things on that front, so that providers who were doing well, they became part of our preferred provider network. Members could see who the preferred providers are, and making sure that they're aware and informed of their healthcare decisions. And then increasing provider and member satisfaction. If those look familiar, but that aligns with the triple aim that we focus so much on today. So in more detail, what did we do with the state? We made sure that we were aligned with the political commitments that were made by the administration. You know, when you have a governor and you have the Medicaid Bureau saying that they want medical behavioral integrated health care, they knew what they wanted, but the logistics of it and what it looked like, they didn't have a lot of clarity on. And frankly, you know, I've worked in probably about half of the states in the country so far in the years that I've been doing my job here. I would say that's the case in a lot of states, where state officials, they want integration, they know what outcomes they're looking for, but they're not exactly sure what it would look like. And so there's a lot of value in that. You can adapt it based on what the market will support and what makes the most sense. We made sure to partner with governing agencies and work with them around change. For instance, there were significant issues around licensure, where medical providers were licensed in one state department and behavioral providers were licensed in another state department. They weren't working together, and they created all kinds of barriers to integration, and partnering with them to help make some changes. Having open dialogue with state officials, letting them know, you know, what opportunities that we're seeing, what challenges we're seeing in moving towards integration. And partnering with them, it's really amazing how much they can help reduce some of those barriers that you're finding in partnership. And we made sure to engage all of the stakeholders in provider advisory committees, behavioral health advisory committees, reporting into our quality structure, as well as the executive board, so that we had their voice regularly being heard in guiding our operations and where we're heading in concert with them. And then leveraging all possible funding streams. So we looked at the continuum of care, and as, you know, say crisis services or crisis stabilization units, or things that are funded that are outside of the covered benefits, making sure that they're still a part of the continuum of care, and that we're working with them and including them so that members don't have any barriers because of a lack of communication. Any questions around state or anything people have? Okay. The health plan, and this is probably one of the areas of most interest for you. When I started, there was a lot of, well, we're medical, well, we're behavioral, or, you know, or we're options, and people were basically identifying themselves in a way that moved away from integration. And the leadership took a very concerted effort in removing those barriers to integration. Words are aligned with people's thinking. And if you have an RN who believes that they're medical, and you have a behavioral health clinician who believes that they're focused behavioral as opposed to holistic health care, then you're going to have an ongoing barrier internal to your operation in getting them to not only work with individuals holistically, but seeing them holistically and doing care plans with them and trying to overcome and meet those care opportunities across all of the individual's needs. So really smoothing out that language. Had clinical cohorts developed where individuals who were of different disciplines became a team. And we did this, in UM, within the office, where we had RNs and social workers and behavioral health clinicians and peer support, and they made up a team where they had team meetings and they did their own staffing and had, ongoing consult with each other. We integrated seating so that you didn't have specific disciplines sitting over here and another discipline sitting over there. They were integrated in their seating as well with their cohort. And then made sure that there was basically what we call an areas of expertise log, where we list out all of the clinicians and individuals that we had on staff and what their areas of expertise were. So, for instance, one of my background's in forensic psychology, so I would be listed on there for forensic psychology, and it didn't matter which cohort I was part of. If something came up around criminal justice, then individuals knew that they could tap on me for a consult as needed. And that was on a shared drive, so it was accessible to all the personnel. Having a clinical platform that supports integration, has all of the medical, behavioral, social determinant information accessible to everybody on the team, and having reports that provide information around where you are in promoting integration. So choosing your metrics carefully, making sure they're measurable, and then measuring them and using that information to guide you as you continue to move around integration. We set up a single call center, so it didn't matter member or provider, medical, behavioral, it all came into one place, and we're able to work with individuals that way. We made sure that the state, as well as providers, and in those advocacy committees, that they had an idea of where we were in moving towards integration. Had interdisciplinary care teams, and made sure that on those teams that the member had a primary point of contact. So they didn't have 5 people connecting with them for different things, but they knew that this was their person. This was the one individual that they could call on if they needed to. And then, because we did population health, and you don't always have claims information to be able to do, the analytics to determine the highest risk factor, we did a hierarchy of case assignments with individuals came in. If we only had an HRA, health risk assessment on them, we would be able to find out where they would best fit, who would be best to serve them. Not perfect. It wasn't that it didn't get adjusted as individuals changed or we had more information, but it gave them a primary point of contact and a starting place, especially if the individual was high risk. And then we made sure that we targeted case integration at all levels in the continuum of care. So we looked at integration in inpatient settings, intermediate settings, outpatient settings. If an individual went into a psych inpatient facility, were they really looking at the individual holistically? Was their discharge plan holistic in nature? Did they engage outpatient providers in those transitions? We instituted evidence-based health risk assessments as well as condition-specific assessments that were available to our staff so that they could administer a PHQ or a GAD or, you name it, if they felt like during a home visit or they were talking to a member that there were symptoms there that they wanted to explore further. And then, of course, we had ongoing meetings that included not only our clinical staff, but also networks to identify opportunities and to really solution to have a full continuum of care and develop services needed. Any questions or comments with regard to, from a health plan approach? Okay. On to provider. Okay. So from a provider standpoint, where did we move the needle around integration? First thing we did was for providers who actually were able to integrate services or had already integrated services, we moved towards a single contract with them so that they didn't have to negotiate separate medical and behavioral contracts. That helped considerably in their being able to have, single claims payments and have, all that documentation together. We adapted integration to care settings and geographical area. So this goes back to that continuum again. What you can do for integration in a metropolitan area versus a rural or even frontier area can be different. And adjusting based on who the providers are, leveraging the strengths in the given community. There are frontier and rural areas that I've worked in who've just done phenomenal things around integration, but they've been very creative in what they've done, so it's not something that there's already a predefined model for. So supporting that as you go. Doing ongoing assessments of provider capacity, which is not just geo-access. And geo-access tells you where they're located. It doesn't tell you if they're accepting Medicaid patients. It doesn't tell you, how their practice is going. Are they looking at expanding? So really making sure that communication is open with providers. And then ensuring that providers had an active voice in moving towards integration. We did requests for information. And the requests for information were put out to provider and advocacy groups, consumer operated services as well, and basically posed to them, this is what we're seeing within this market, and we want to move towards a more integrated care model. What are your ideas? What creative ideas that you have to promote integration? And then we move to contract new services, new ideas, so that they each had a great idea of how to do it. And so we did. We listened, we contracted. And we also promoted technology, telehealth, having child psychiatrists able to consult in pediatric practices and so forth. We issued a toolkit for healthcare professionals that provided direct access to clinical practice guidelines, to free evidence-based assessment tools that they could incorporate into their practices, how to contact and receive assistance if they have an individual that has behavioral health needs in their PCP or pediatric practice. So we wanted to make sure we got as much information out there as possible for the providers. And then targeted integrated models at the highest volume care providers first. So moving those high volume providers towards accountable care communities, towards behavioral health homes, or if there's not an approved SPA in the state, which Tennessee does not have an approved SPA, state plan amendment for health homes, we still work with them to have health homes that are very similar to one that you would have formalized if there was a SPA in place. We created value-based services, and those value-based services were not in the benefit package, but they closed gaps in care. So, for instance, one of the things that we saw is a lot of people sitting in state hospitals because they had behavioral health conditions that allowed them to be able to enter in the community. but they also had ongoing medical needs that made placement basically scarce, if not non-existent for them. So we created an enhanced supported housing with the state's approval that overlaid ongoing medical care into supported housing settings. And we made sure that the best practices that were already in place were capitalized upon, that we utilized them, and that we made sure that other providers had the ability to consult with them and work with them too. And then finally, putting provider measures in place to incentivize them and to hold them accountable for outcomes. So, for instance, our ACE program is a tiering program that is identifying preferred providers based on their efficiency of care as well as the quality of care, and value-based purchasing as well as scorecards and other mechanisms so that they would have regular ongoing feedback about how they're doing. Any questions or comments around the provider initiative? Okay. Next slide. So lessons learned. Knowing your customer, your providers, your members very, very well. They are very open to share information with you. They are very vocal in most instances, giving them a forum to do that. And listening to what they have to say and making them part of the solution, whatever that solution may be. Start the integration at the level supported by the current care delivery. We talked about that on the continuum. Measure key indicators regularly to make sure that you have metrics defined that are measurable and that they are being looked at on an ongoing basis to make sure you're going down that right path. And revisit and revise key indicators if things are coming out that aren't what you anticipated. Integration that looks great in one state and is evidence-based there may not do well in your state. So, you can look at it and use it as a benchmarking, but adjusting it so that it fits where you want to go, what it is you want to accomplish. And one size doesn't fit all. We talked through that. Co-location is not integration, and that, I think, has become, a drum that's been beaten quite a bit. Where we've had practitioners where they locate in the same office, they don't share records, they don't communicate, they don't do staffing together, really doesn't get you there. And there's a lot of literature around what exactly integration is and what it looks like beyond just that basic location. Leveraging evidence-based practices and adapting to fit your market. Top-down messaging and mindset are critical to your leadership buy-in. Really impact your line staff. What's the messaging from the top down, and is it consistent, and is everybody in agreement? Because if your leadership isn't aligned, you're going to have a lot of problems with the line staff and how integration is delivered, if it even gets delivered well. And then finally, human nature gravitates back towards what's comfortable and known. So if you have staff of RNs, and they have a background in medical care, they're going to want to gravitate back to medical care. Behavioral health, asking someone about their depression, asking them questions about, any suicidal ideations or history can be uncomfortable for some clinicians, and is educating and supporting and constantly making sure they don't gravitate back, that they continue to see and work with individuals holistically. And then as far as outcomes go, under the next slide, there's a number of outcomes with regard to what we put in place in Tennessee, starting back in 2007 and even to date, and continue to modify and refine over time. But what we've seen are, double-digit decreases in inpatient admissions, length of stay percentages, bed days have gone down. The first two bullets there are two, large practices that we have and what their specific outcomes were. We saw marked increases in follow-up after hospitalization rates for individuals engaging in care as well. And so you can see those last two bullets there as far as from a HEDA standpoint, what we were able to accomplish with this model. around integration, working with providers and members. Next slide. And then with this collaborative management approach, working with providers, doing peer-to-peer shaping of care, doing interdisciplinary staffing that included the providers as well as the members at times, having a feet on the street approach. So, today we use community health workers, which has been an evolution in the market. Working directly with them, we've been able to reduce inpatient admissions and readmissions across the state, and that we actually decreased inpatient utilization by 16% in 1 year. And so we continue to see a year-over-year decrease in the inpatient utilization as a result of getting that care in the community and closing those care gaps. One of the services that we instituted that the state supported is comprehensive child and family treatment, and this is a community-based holistic treatment for children who are at risk of institutionalization or residential care. We have diverted basically an average of 57% of children and youth that would go into residential, and then be able to go into the community with the CCFP program. And you'll see that last bullet there. Over the course of a 4-year period, we did about 2,600 in-home evaluations where we looked at diversion alternatives and were able to divert almost 50% of individuals into community care as opposed to institutional care. We embarked on an initiative to really have individuals come out of state hospitals as well as individuals with high risk linking with peer support services. And the community living approach as a cost-effective alternative of care allowed us to get 52 individuals out of inpatient settings in the matter of a year and reduce their overall cost of care by 62%. So those are high-risk folks with medical and behavioral comorbidity. And with the peer support, we were able to not only reduce overall death days, but also decrease the number of admissions that individuals had with chronic behavioral health conditions. Next slide. Okay.
Can I take something else?
No, that's it. Any questions or comments with regard to the Tennessee case study? Or any additional information you guys would like in follow-up that I'm happy to send over to Carol and Natalie?
Hi, this is Leanne from Alaska. Thank you so much. That was really, really great. I have a couple questions. So the supported housing, so did you come into problems with availability and capacity of housing? And if you did, how did you remedy that?
We did it first, and this is where the partnership with the state helped so much. Their office of, it was the Consumer Affairs Office, they embarked on what's called the Creating Housing Initiative, or CHI, C-H-I. And they basically worked with community mental health centers and funding sources, 501c3s, and really helped drive additional housing options to become available. And so on the front end, they helped build out like the bricks and mortar with the provider community. And then from a service standpoint, we contracted and put both the behavioral and the medical housing options in place for the care options, and then later added peer support services. So, peer support is a wonderful evidence-based practice to help individuals. And so having that peer support within the homes as well really helped to stabilize individuals in the community. So it was really using your housing support, your state agencies, and the services that we put in place.
That's really good. And I would actually love to have more information on that.
I have another question about the health plan. So I saw the health plan. Was that just a Medicaid health plan? I saw United Health in there as well. So did you have everybody on board, the commercial, the government, Medicaid payers, for that one health plan for the patients who were in this bucket of behavioral health and physical health? So United has members who are Medicare, commercial, Medicaid, all within Tennessee. The case study and the results that are there are focused around Medicaid and then the Medicaid, Medicare duals. Okay, great. And also I'm really interested on feet on the street. I love that term for your community health workers. Were they embedded into the health plan in this whole program? At first, no. What we had was clinicians who were doing a lot of the field work. And as we looked at it, not only do you have the cost with having that many clinicians for a feet on the street model, but a lot of the work that was being done really didn't require a licensed clinician. And so what we did with our field-based teams is put community health workers, peer support specialists, which are certified paraprofessionals but not necessarily licensed, behavioral health clinicians, and RNs, so that we had a mix. And then the community health workers would do more of that face-to-face engagement. Peer support would be for high-risk or emerging risk folks in the community. And then the RNs, the behavioral health clinicians, would be engaged based on individual needs, but focus their efforts really around use of their clinical skills. Great. Thank you so much. And I'm hoping I can reach out later and get some more information from you. This is really good stuff. Happy to.
This is Tracy from SIU School of Medicine, and I just was going to mention something around housing that really came in use in our community that I was really surprised. Is we partnered with our local neighborhood associations to take abandoned homes that they had in their neighborhood that they had bought through their TIF, and help them to restore them and then rent them out to our patients who had complex health crises. And then we brought our mental health and our FQHC together and provide services for those individuals in those homes. And most of those have disabilities, so they're paying for their rent, which works good for my neighborhood association that was having a difficult time renting those places out. And so far, those patients have been stabilized in those homes for a year and a half with no issues. So I had never really thought about working with a neighborhood association to address housing, but it really did lead to some great examples of outside the box thinking with housing.
That's great. And again, it goes back to that concept of individualizing to the given market and looking at where the strengths and the assets are. As we've learned more about and talked more about social determinants now, and the reality is that if you want to improve individuals' overall health care, you're really going to have to address those basic needs like housing and employment and individuals being able to meet their basic health care or basic needs. Because if they have a choice between eating and paying for their medication, they're going to eat, And so, and any model that looks at integration really has to include the social and environmental factors. And that's, again, moving beyond that comfort level, where you're asking, clinicians and healthcare workers to really go beyond just focusing on healthcare. But that's what study after study has shown us, that if you don't meet individuals' basic needs, you're not going to get any further. So it's like partnering with, not only the housing agencies in your area, but, past homeless programs, find out who your past providers are, who those grant providers are in your area, and make sure that they know you and the services that you provide, that you guys can have a relationship.
So, Leah, I think there's some other things in what you said. None of this happened day one. It took time. And you've got this notion of a kind of a system of care, a systems perspective, and then you're creative about how you add to that system, both, what types of services or organizations, and then what your relationship is with those organizations. So, those of you may be asking, well, why are we talking about a health plan here? The fact of the matter is, if you're becoming value-based, if you're entering into value-based contracts, you're taking on financial responsibility, which is what a health plan does. And so, we're hoping that there's some messages here that begin to get you thinking as you take financial risk, what sort of responsibilities come with that, but then also what sorts of possibilities come with that. So Leah, there was a question, what are PATH providers?
PATH is Projects for Assistance in Transition from Homelessness. It is federal funding, block grant dollars that states apply for. So whoever the state mental health authority is, they apply for funds, and then there is a state contact in every state, as well as grantees. And the grantees can be SQHCs, community mental health centers, and so forth. And what they're tasked with doing is basically assisting individuals, inclusive of individuals with chronic medical and behavioral health conditions, in moving from being on the street into stable housing and care. And so when you think about, as a care provider, individuals who, you frequently lose contact with, they're very difficult to keep engaged. If they're, transitioning in and out of homelessness, knowing that PATH provider in that area, making sure that they know that you're, working with this individual, they can be invaluable in that care team in meeting the individual's needs, because while they're more focused on housing and food and showers and all those types of basic care needs, they're going to be looking to the care providers in assisting this individual if there's need for medication, linking them with appointments and so forth. So, I've always appreciated PATH in that if you guys have a very difficult high-risk individual or individuals, chances are they're going to probably encounter that PATH provider. And I'm happy to send a link of that information, as well as information around the Creating Homes initiative out of Tennessee, to you, Natalie and Carol, if you guys want to share that with the group so you guys can explore those options further.
That would be super, Leah, and we'll make sure that the group, feedback from the last set of sessions was that people wanted as many practical tools and information as possible. So, we would be delighted to make those available. Thank you for that, Leah.
Oh, you're welcome. And if there's any other feedback from the group as far as anything in the presentation that you want more information about, don't hesitate to ask. I have a lot of source documents and explanations around the content here.
Okay, ladies and gentlemen, she's about to turn into a pumpkin. Ask now. All right, Leah.
Definitely. I would love to hear more and learn more about your programs.
Okay. All right, anything else before we let Leah go? All right. Leah, thank you so much. I really appreciate it. We hope you do not get stuck in traffic as you bolt for your airplane.
Yes, thank you. Have a good one.
Bye-bye. Okay, so since we did things in a slightly different order, we're going to go back quickly and we're going to pick on somebody to go through the homework. But we're hoping you see how this arc fits together. Now, Leah's stories about integration were about people who had medical and behavioral health issues and, what integration meant as a health plan in that context. But this notion of going back to needs analysis, whether it's through claims, whether it's through what you have in your EMR, whether it's through assessments or just simple demographics, the point is to really understand what the needs are for the group of patients that you have in a value-based contract. So one of the early kind of boxes to check in this journey is to assess that there really is leadership, understanding, and support for what it is you're trying to do in a value-based world. So I think the homework last time was to take a piece of an assessment that we traditionally do with our clients to assess kind of where they are in their value-based journey, and look at the questions and answer for yourselves, as honestly as you want to be, to the extent to which your leadership is really on board in starting this journey towards value-based contracting. Carol, is that kind of how you teed up the assignment?
Yeah, we gave you guys the tool. We asked you to work not only if you're on this phone call by yourself or your whole team, take it back to your team and do the exercise. We also threw some questions out there like, what kind of contracts do you have now, any new opportunities, but we want you to think about that and use that with your leadership group to, how did the exercise go for you? What were the results? And everybody's going to get a turn presenting. We've got, one session down, this one, and I don't know, 4 more after that. Everybody presents. So I think we're looking for 2 volunteers at this point.
Hey, this is Andra from Seward. We'll go.
Yay! We love these Alaskans. Awesome.
So there's a couple of us here. Myself and Kelly, we work with the Seward Community Health Center, so our local FQHC. Then we have Kathy here who is with the hospital. And going through the questions, there's a lot of things that we don't do, that we're not there yet. We don't have any kind of contracts that you guys are referring to. And we're starting to move towards becoming a PCMH, and so we're moving towards going for, and I can't remember what the acronym, the P for P, the payment for performance. Payment for performance. Thank you.
Yep. Up
from a fee for service, and we're slowly moving in that direction, but we're not quite there yet.
That's great.
Yeah, I'm curious on. Sorry, I just had a question in addition to our homework. When it goes to the pay for performance, the only thing that I could kind of make a similarity to would be kind of how we get money from grants, in which case we would have incentive to do, for instance, developmental screenings, which would technically be, preventative services that in turn would decrease our costs. But I don't know if that falls under the same payment for performance category contract. Did that make sense?
Yeah, it does make sense. And, performance is kind of in the eye of the beholder. So, what does the agreement look like between you and whoever is funding this? And, are you meeting the agreement? Whether it's, we have one client that's an ACO and their payer wants them to complete, a proportion for an expansion population of both wellness visits and health risk assessments within a 12-month period. So, is it sub-capitation? Are they financially fully at risk for all the medical expenses of that population? No. In this case, what the performance is requires that some screenings and preventive services are done, and that's how performance is defined, and each contract's a little bit different. So, the question would be then, all right, it's wonderful, and you're getting done what you need to get done, and are you ready to take on a little bit more risk? For example, if you really believe that these types of services that you're providing have a positive impact on overall health, and you can demonstrate that by reduced say, reduce emergency visits because there's now a better relationship with primary care providers at the FQHC. You know, would you want to negotiate with the funder, you know, probably not the grant-making agency, but a payer, maybe the state Medicaid program, for a share of the equivalent dollar value of those visits that didn't occur, that you helped reduce?
Oh, yeah. So instead of going to the ED, they would have been able to see us, and we could have reduced the cost there.
Yeah.
Yeah.
So, you know, it doesn't mean you have to jump in, you know, and take full financial risk and have a contracted network and all these other things right away. But, you know, where is your leadership with regard to saying, okay, we've kind of cut our teeth on pay for performance by, you know, and we think we can get our organizations to do things a little bit differently. We're now ready to take on a little bit more financial risk. For example, if the things that we do, the programming we offer, the services and the kinds of partnerships we have with others in the community really do reduce inpatient use, we want a share of that so that we can grow future programming.
Cool. Thank you. Yeah, that's applicable to us. We ran into the idea that a lot of contracts we were looking at through insurances had to have a patient base that was much larger than what we have complete for our total patient base. So
Our total population base here in Seward, right?
Yeah.
Yeah, and as far as leadership, we have an amazing board along with our, you know, executive director, and they're more than willing to take a look at anything that kind of moves us in that upward direction and how we can, I guess, perform better for our community and for our patients. And yeah, just going through that leadership assessment, just looking at the questions, I don't know if I would answer strongly agrees to all those, but definitely, you know, agrees and, you know, take a look at to see what we can do to move in that direction.
Okay. And do you think more strongly agreeing would be necessary for you to take on more potential financial risk and upside to get into a kind of arrangement where if you reduce emergency department visits, for example, you know, there's a dollar savings associated and they'll split it with you 50-50.
Right. I would say strongly agrees to discussing the possibilities. Yeah.
Okay, cool.
Yeah, I think it, right now with where we're at with our medical director and our executive director, they have their own strong opinions on financial pieces, and one is a little bit more conservative, and so it's definitely, I would say, worth that conversation and bringing the information to them to see how they felt about moving towards more risk.
And I think that's okay. This is Sherry Elmy from Optum. I think that's okay because one of the things that even Leah talked about was that strong leadership. And so the leadership, if the leadership is aligned, you're better having those messages be more consistent to really support the work that has to fall underneath. So that's just fine.
Okay, who wants to go next?
This is Megan from Hudson River Healthcare. I can go.
Okay.
Okay, so just for a little bit of background, we at Hudson River Healthcare, we're a federally qualified health center in the state of New York. We, about 2 years ago, started an IPA in collaboration with a set of what was 7, it's grown to 9 behavioral health providers in our local community. So that IPA is established, it's a separate LLC, and it is jointly owned and operated by the health center and our behavioral health partners for the purposes of doing value-based contracting for integrated primary care and behavioral health. And at this point in time, after quite a lot of discussion with one managed care organization that was forward-thinking and willing to work with us in the early stages, We are currently in a value-based agreement with them. It's a short-term 6-month arrangement that's intended to really be our sort of on-ramp to more sophisticated value-based contracting. Our current arrangement is structured more as a pay-for-performance type of arrangement. What we have is a PMPM care management fee, and then we have 2 different performance incentive buckets that we can potentially earn. So one is around improvement on a set of 8 quality measures, and then the second is on specifically geared toward reduction of the rate of non-emergent ED utilization. And so we're working under that contract right now with the thought that we are going to move into more of an upside-downside risk model for 2017, and we are just now scheduling our conversations around that contract, to take place over the next couple of weeks. And then in terms of what we did in looking at the, so that's sort of a description of what's currently underway right now and what we're looking at for the near future. In terms of what contract model is most logical for an organization to enter into, really it's upside downside risk, because that's all they've given us a preview of what 2017 is going to look like, and we're really more moving towards hammering out the specifics and the details of that. We did complete the leadership assessment. I would say, we're very much ready and already doing P for P, and sort of maybe even you could call that upside risk for the current arrangement, and preparing ourselves and have a strong vision for the upside downside risk. I was just saying to my colleague Allison, who's sitting here with me, on the bundled payment line, I wrote in strongly agree on a bunch of them, but I sort of to reflect that we strongly agree that we're not interested in bundled payment. We've got a clear vision, and it's not for bundled payment. And I think where we start to, we have a lot of interest and would be looking at it, but I feel like we still have work to do on, strengthening our vision and our readiness for that. But on a full cap or a global cap model, I'm still feeling like we have work to do in order to be ready to move forward with something like that.
What would it take to convince some of your leadership that this is a desirable strategy for the organization? You joined an IPA.
A lot of people who are convinced that it's a desirable strategy. I think it's getting the devil's always in the details. So figuring out what's included in the calculation of the total cost. Would there be anything excluded? Could we really? Would they require us to have certain reserves? It's all of that. It's the pieces that we don't know yet, and we probably wouldn't know unless we got into specific conversations with a managed care organization around what would be in a contract like that.
Okay. And so, as your board got excited or your leadership got excited, the devil's in the details. What other kinds of caveats or reservations might there have been that you worked to overcome as you pushed for more value-based?
I think some of the things that we've had to work on and overcome as we are moving from more of our P for P model and to become ready for this upside downside risk model in 2017 is what does the standing up of this integrated clinical approach to primary care and behavioral health really look like, and getting through operationalizing that. I think we have firm commitment from all of the folks involved in the IPA that's the right way to go, and that's what we want to do. But when you get into the day-to-day work and how it actually happens, we're hammering out a lot of details, and I feel like I hate the metaphor of building the plane while you're flying it, but we really it's applicable in this situation of we have had to in short order because of the short 6-month contract period that we're in right now, had to develop at least a starting place and an interim approach to how we were going to risk stratify our patients and who was going to be eligible for care management. How is that care management being delivered? How is it being tracked? How are we measuring our performance? All of that we have had to just sort of dive in and tinker as we go.
Okay. All right. Those of you who are willing to share, thank you so much. We're going to pivot now to the last segment, which is your homework assignment for next week. So we have talked about, different, last time I think you talked about different types of value-based contracts and the ins and outs of those and how you look at a contract and key concepts and terms to think about. This time we have talked about looking at a population and figuring out what integrations might be important by understanding cohorts within the population and what those cohorts might need. And then we had Leah talking a lot about integration from a medical behavioral perspective and a community perspective in the context of health plan in Tennessee. So for the homework this time, what we'd like you to do is take a look at a cohort. If this is all you knew about one or both of these cohorts, what kinds of care would people in these cohorts need? So for example, what sorts of services does somebody with Gaucher's need, if that's in your rare high-cost conditions, or sickle cell or hemophilia or other more complex conditions that we don't see a lot of? What's the clinical care they need? What sorts of supports might they need? And then whether it's community-based support, addressing social determinants, and then how would you think about your options for integrating services and support to better serve people in these cohorts? So think of it as sort of a brainstorming exercise. Take one of these cohorts, or, if there's a cohort you're working with today, use your own. That's perfectly fine. We just thought we'd give you some ideas here. Be able to describe what this cohort of people needs, and then where you're going to think about getting the services needed and what your relationships with these service providers need to look like. Does that make sense for a homework assignment?
Yes.
Yes. Okay. And the reason we're asking you to think about this is because, the structure of your value-based contract in some ways says a lot about the kind of relationship you need. If you have full financial risk for all the care for a cohort, then you probably need to think about a contracted network. Because, maybe you can get all the services you need under kind of one roof, and you're an integrated delivery system and you have everything you need. But chances are, in the safety net, that isn't quite where you are. So how are you going to form the relationships with others in the community where together you will help serve a particular cohort? So we're pushing you to think about, first of all, just who is the cohort, what do they need, where are you going to get the types of services and supports you need? And that's homework for 2 weeks from now. Any questions, concerns, like why are we talking about this, feedback?
I think it's a great exercise. This is Leanne from Alaska.
Okay, going once, going twice. Please remember to take the Survey Monkey because this is your time, and we need all the help we can get to make it as useful to you as we possibly can. So really love the feedback. Good, bad, anything. Let us know so that we can adjust to make sure that this is valuable. You guys are busy.
Also, the notice on the attachments that you can download, there is a small article on risk adjustment. I know there was a question last session around that. So it's an article that will give you some ideas around what that is and different risk adjustment models.
So this is Stephanie from Providence Family Medicine. Was that survey emailed out? I don't think anybody here received it for last week.
The leadership survey or the survey monkey?
Survey monkey.
Yeah, you should have received.
You see on your screen there's a box. It should be to the right of the presentation. It says chat.
Okay.
And AJ has put a link in there for Survey Monkey. Can you see that?
Yeah, I saw it earlier. Last week, or last time, it was mentioned that it would be emailed out, so we were kind of waiting for that email. But
right,
sorry about that. No.
Just so you know, I send out those emails to each of the team captains, and I'm hoping that each of the team captains will forward those emails to each of you. So that's how we're going to do it based on that. So I'll do that again, and hopefully that works out this week.
Okay. Is that the overall team captain, so like Leanne for Alaska, or is that the team captains for each individual group? Like,
Leanne is the one I'm in contact with for all of the Alaska group.
okay.
So AJ, should the Alaska group submit one joint evaluation, or the Seward group and the Providence group, they each do their own, or how do you want it?
It would be great if as many people who attend the session can just fill out the survey. So I'll make sure that you'll see the survey pop up right as we end this session, but I'll also send out that email to Leanne, and hopefully we can get that out to all of you.
Yeah, this is Leanne. I'll make sure to do that this time. Sorry.
So next session is October 18th, same time. If anybody needs help, we had some technical difficulties in the beginning. It's okay, where everybody's new to doing this. If you have any issues signing on, downloading documents, it's okay. We want people to learn and come along on the journey with us. Please reach out to AJ. He's a great instructor. And okay? And if you have any questions with the homework, it's Carol. My email is in the beginning of the PowerPoint, but we'll talk to everybody on October 18th. Have a good 2 weeks.
All righty. Thanks so much.